Morning, everyone. So I'll be talking about biometry and how to measure it right. So as we all know, there are three basic important investments that we have to make in our private setups. One is a good microscope, one is good phaco machines, and last but not the least is a good biometry machine. And now, as we all know, cataract surgery has evolved into a refractive cataract surgery with the advent of toric, trifocals, zeta of IOLs, patients demanding a spectacle-free life. And if we calculate the axial length, any error in axial length of 1 millimeter would lead to a 3 diopter error in the refraction of patient, and similarly 1 diopter of keratometry error could lead to a 1 diopter of a refractive error in the patient, which we simply cannot afford in these times. So this is how over a period of time the biometry journey is there. So it started from the ultrasound biometers, now coming to optical, and latest being the swept source OCT based biometers. So coming to the ultrasound, there are two main important ultrasound based biometers. One is contact applanation and the other one is immersion. Contact is now, as we all know, it's almost obsolete because it involves the corneal compression and it can lead to erroneous measurements. Second one, which is an important one, is an immersion A scan. It minimizes technician variables, gives us more reproducible results, and this is how it is done. So we have to make adjustments we have to ensure good spikes and gain adjustment. And this is a video of our optometrist doing the biometry. So it's very comfortable for the patient as well as for us. And in normal cases, you can see the lens star reading is almost similar as immersion. It is exactly the IL power is exactly same. But yes, we have to make various adjustments in various eyes like staphylomatous eyes with macular lesions, dense cataract, silicone oils, etc. So the advantages of current optical biometers over conventional immersion A scans are: one, that it measures the axial length from the corneal vertex to the photoreceptor instead of ILM in A scan. It calculates the ultrasound biometry calculates the anatomical axial length, whereas optical one calculates through the optical axis, which again is more reliable. So the accuracy of optical axial length is almost as near as and as good as 0.012 millimeters. In pseudophakic, aphakic, phakic IOL eyes, the more accurate biometry can be done, and the kind of material used has less impact on axial length measurement. It is more precise in in special eyes like myopic eyes and silicone oil filled eyes. So we have a host and we have a stack of options to choose from. So the optical biometers can be divided on the basis of the technology. First one is partial coherence interferometry based biometers. In this, Zeiss IOL Master 500 is the prototype, and it is based on the interferometry, and axial length is measured. Then came the OLCR based refractometer biometers. So the Lenstar 900, which we also have, is the prototype. So it permits a full A scan of the entire eye, including the retinal thickness measurement, which is possible. The other ones are Galili and Aladdin. So the key features of Lenstar is that it measures only when the patient fixates. It ensures the measurement is axial, and we get all these 9 measurements in one go with a great accuracy, of course. So this is a typical printout of a patient's eye with cataract with the IOL formulas. It has all the latest Barrett's Ostlund formulas, which help us in premium IOLs and others. So it also gives us angle kappa value. And the keratometry is dual zone keratometer. It is on the visual axis and it has high resolution with 32 points. So the keratometry measurements are also very accurate. The main two disadvantages with this system is that it is not possible to do in dense cataracts and hazy media. So for at least 30 to 40% of the patients, we have to resort to ultrasound or immersion biometer. And also it lacks the total keratometries, which I'll be explaining later on in my talk. So the latest set of biometers are swept source OCT based. So Xyl IOL Master 700 is the latest, and also Argus from Alcon. So these are the prototype. You can see how the IOL Master measures. In less than 45 seconds, the scan is taken, so we are done. So it makes the life easy, and workstation is less busier. So what are the new features in this? It has a B scan star pattern, it has 3-zone keratometry, white to white image is shown, and most important is the fixation check, where you acquire it when you see the fovea. So that helps in ensuring that yes, it is the correct scan. So you have to see the foveal pit. If it is not there, then it means the patient is not fixating properly. So we can also detect macular pathologies also with it. So with its superior cataract penetration, the densest and the most dense subcapsular cataracts as well, we are able to achieve a good biometry. So even in grade 4 cataracts, it is easily done. So with our own experience, after we took IL Master 700, almost 90 to 95% patients, they do not need immersion, while earlier the percentage was as low as only 50 to 60% cataracts we could do lens star. So these are all the measurements which are very easily and precisely given by this machine. So now coming to the total keratometry measurement principle. So basically we know that the posterior corneal curvature also contributes to the refraction of the eye. It is 1.32 diopter more steeper than the anterior, which can cause variable in the biometry, especially in patients with post-refractive surgery eyes. So basically this overestimates the corneal power by 1 diopter for every 7 diopter of correction of refractive error. We have to use special formulas like Sharma's and Barres-Truquet or an Ascaris calculator for calculating biometry. So they have incorporated, this is a true K, which is a keratometry based on a, I'll just show it again, based on posterior corneal values and calibrated similarly. So this is a typical scan of the patients with cataract eye. You can see the keratometry values here, K1, K2, and TK1 and TK2 is the true K1 and true K2 power. So just a practical tip, if the patient has with the rule, this is actually very important in while we are putting toric IOLs. So patients who have with the rule astigmatism, TK would be lesser. So patient may not need toric. Whereas if the patient has against the rule astigmatism, TK would be more. So we should go more towards the toric side. Again, we can calculate angle alpha and kappa, and if their sum is more than 0.6, we should dissuade the patients for the multifocals. So I would like to conclude by saying that accurate IL power planning is as important as doing a good surgery. Patients should see clearly without glasses should be the aim of the surgery. And coming with IOL masters and newer technologies, the focus on toric lenses has increased, and why not? It should be there. And with with a lot of patients coming with post-refractive surgery eyes, the IOLs they demand a spectacle-free life. Immersion scan works for most of the cases, like almost more than 90% cases, it works very well. So initially, we must buy the optical biometers, and source OCT biometers are a must buy. After our initial setup is complete and after the immersion scan, our finances are good, then we should plan and upgrade. Thank you.
Thank you, Deepa, for an extensive presentation. I think we can have quick questions because we have a lot of time. Deepa, I just wanted to know that you spoke about angle alpha and kappa. In how many of your multifocal patients do you always look at these values when you are choosing a multifocal or a EDOF lens?
We do see it, ma'am. If it is very high, if it is more than 0.6, 0.7, we'd like to dissuade the patient. But yes, there are studies which have proven now that, there was a study in Southeast Asia, and almost they had like 2,000 patients, and they say that it doesn't matter. There are a lot of other variables also. So it has to be taken in the patient profile, and a lot of other variables are there which need on the basis of which we implant multifocal IOL. So I would say that it is just one of the consideration. It is not a clear cut no.
Any of you have these the higher end which sorry, I'm just forgetting the name, which measures the angle alpha actually by ray tracing, eye trace.
Eye trace.
About this, but regarding these two, Lenstar and iOS Master 7, then if you actually see the logic behind it, it makes sense.
Because
Because we are putting it in the geometrical axis
and
angle alpha and kappa is different. And the rings are starting at 0.41. So for any trifocals, I actually take it. But in case I feel it is lower, then I would shift to a mirror.
I just why I asked this question because I also have IL Master 700 and I have been looking at angle alpha. You measure that CWC and XY
XY,
and you
then you can.
get those measurements. To my surprise, lot of patients. If I would say 100 patients, out of that almost 40 were having an angle alpha was more than 0.6. So I was wondering that all these
So
patients
it's
will be
not,
rejecting from
yeah.
multifocal, but if you so then I did send couple of patients for eye trace and I found that in eye trace the angle was still within the
Within
0.6 range, so you
0.6.
could still implant. So with the IL master, though there's no published literature, but I feel with IL master 700 the threshold of putting a multifocal could be increased to 0.8 rather than 0.6. बिकॉज उससे क्या होता है कि वो हम बहुत सारे रिजेक्शंस कर देते हैं
Yeah.
एंड देन व्हेन यू सेंड दोज पेशेंट और दे आर कमिंग फ्रॉम समवेयर एल्स जैसे कि भी एलिजिबल है पेशेंट तो that's what I have a personal, I mean, I no published data, but that's what I personally feel. And anything else that you wish to?
One more thing which always occurs to my mind.
This
What is the till what time do we consider our biometry as valid? So many a time, let's say a patient had come an year back and gotten his biometry done, and then he wants to get his surgery now after let's say 6 and 9 months. So the patient is like, "Doc, sir, ये सारी जांच तो हो रखी है मेरी." So are we following a timeline? So I randomly decided that okay, if it is more than 3 months, 3
Yeah,
months.
it's more than 3 months. We
I-
should repeat,
cool.
especially in toric IOLs.
Yeah, there is no guideline for this.
Yeah, yeah. That's what
But
we
surprisingly, I have found changes.
do.
So there was a
Especially,
patient. Yes.
yeah, especially if you're planning a toric IOL, then it's a must.
Exactly.
Very important.
Yeah.
Correct.
Very important.
Yes. Yeah, just for your own psychological satisfaction, it is required. But yes, we have seen that more or less it doesn't change. The
with toric,
spherical,
I have
yeah,
s-
with
I have
toric
seen,
IOLs,
they've seen
it
good
does,
changes.
it does. It
And
can.
is there any consensus on should we do the biometry if the pupils are dilated or non-dilated, or is that not?
Untouched. I mean, without any drop, single drop. First thing you do is
Untouched,
biometry.
yes.
Yeah, but there's a problem
But that's
because
not possible.
that's
or-
not
yeah.
possible. Yes, that's not possible. So I raise this question. A lot of doctors are doing it totally complimentary. So the moment they know there's a
Yeah, so
cataract
even we do
patient,
it
they'll-
complimentary.
but if you're
patient,
charging until unless you see and you advise, by the time some drops
But I
have been
think
put.
all of us end up doing it once the patient is dilated.
Correct.
but you actually find changes.
Yeah, definitely.
Yes.
If you're
Yeah.
planning for a multifocal, you must
There
repeat
are
it.
times when the patient has got a biometry done 6 months back.
6 months
and now
back, come on.
you had
Toric and
toric
non-toric.
and now there is no
Now
toric.
there is no
Exactly.
toric.
I
Yeah, it
had
has happened
the
a lot
IOL
of
was
times.
ordered,
yes.
then the patient was unwell and she came after 6 months and the toricity was all
And
changed.
In fact, I would say that once I did a biometry, I mean, this last week only. At Lenstar, it was 1.8. We did it as in Zio last Master 7. It
There's
was
a
2.3.
There's a lot of
So
ways.
that's a
Yes.
problem
In
of
that
plenty.
cases, I have
That's a
always found
problem of
immersion as the
plenty.
best. If I'm comparing and I have to rely on one, then I'll rely on the immersion values.
But for toricity, there's a lot of change which happens. So whatever is the current one, I
Yeah,
focus
just-
on that.
Don't
And toric
And it is very forgiving.
torics are
It's a very
Even
forgiving.
if you
So
put 0.5 here and there, I mean, it doesn't.
it's that
Yes,
doesn't
the
matter
patient
that
comes out
much.
to be very happy.
The quality of